Okay, and here's some pictures of taking temperatures. You can see the axillary temperature, and then here's the tympanic temperature. Tympanic is the one that is the hardest to do. It's easiest to have user error. You've got to be pointing the little light at the tympanic membrane, which means from the external auditory canal you're pointed sort of towards the nose. If you have it, and so you've also got to pull the ear to straighten that exterior auditory canal. And if you're just pointing it at the skin inside the ear canal, you're going to get a significantly lower temperature than the baby's temperature really is, or that child's temperature really is. Blood pressures. At Children's Hospital they use the Dynamap machines for all the blood pressures, and they're quite accurate. There are a few blood pressure cuffs around, and you can auscultate a blood pressure, but realize the Dynamap is usually slightly higher than if you auscultate, and generally that's done in emergency situations just to verify the Dynamap is accurate. When you're using a blood pressure on a child, you want to make sure that the cuff, it should be approximately 40% the circumference of the arm. The bladder should be 80 to 100% the circumference of the arm. So what you're pumping up covers or nearly covers the whole arm and then just overlaps with the Velcro. The systolic pressure is going to be slightly lower, or slightly higher in the lower extremities. And we can do them in all extremities. Most of the time we'll use the upper arm and do the brachial artery just like with adults. For kids, sometimes they're just chubby and things don't fit right, or they're not cooperative and we have to go somewhere else. We can do the forearm. Realize there you're going over the radial artery though, so it's going to be, you want that little line that says over the artery to actually be over the artery, and for that it's the radial artery just above the thumb. You can do them on the legs. If you're going to do the thigh, you're using the popliteal artery, which is the back of the knee, and if you're doing it on the lower leg, you're going over the posttibial artery, and that's on the medial side of the ankle, just behind your ankle bone. For doing a physical assessment, your textbook goes into a lot of detail that would really be for a physician or a nurse practitioner doing an exam on that child. That's not the kind of exams we do routinely on kids, and it's not going to be on any test for you of how to do those. In the hospital, you should have practiced infant and child assessments and done a checkoff with your clinical instructor. So things to think about on physical assessment of a child. For the chest, this is just like the adult. You're looking at chest symmetry. What's the shape? A child's a little more rounded naturally, where with an adult you're concerned about that barrel chest. So just the natural shape of the chest on a child is a little different, but again, kids who have had some sort of chronic respiratory problem, you are going to see that very round barrel chest, and that's not normal. So you're looking at the shape and the movement, that it's symmetrical and that there's good chest expansion. On your heart or your cardiovascular, you're listening to the heart sounds. You should hear that nice lubbed up, which is your S1, S2. You're also listening for murmurs. You'll hear more murmurs at Children's Hospital probably than you have anywhere else. And with a murmur you get a swoosh as opposed to a click. You're not hearing that valve slam shut. You're hearing blood mixing together. It's sort of like turning the faucet on into a pan of water. You're hearing that sloshing sort of noise. That's a murmur. We're also evaluating, just like with adults, is it regular? And if it's not regular, is it irregularly irregular or regularly irregular? So do you drop every third beat or something like that, which there's a regular pattern to the irregularity, which is a heart block, or is it just totally irregular, which is really worse cardiac function? Lungs, we're listening to the breath sounds. With kids, I want you to describe the breath sounds in more depth than you probably have been with adults. Don't just say they have wheezes. Are the wheezes inspiratory, or are they expiratory, or are they both? Are they anterior, or are they posterior? Are they scattered, meaning you hear one here and then you hear it there, or is it only in one spot, the right upper lobe? Are they occasional, or is it with every breath? So particularly you'll hear lots of wheezes on kids, so I want you to be very specific on when and where you hear them. Also think about how much air exchange are you hearing. An asthmatic who's really bad, you're not going to hear any wheezes because they're not moving enough air in and out of the lungs to create the wheeze. That's actually worse than a lot of wheezing because they have decreased air exchange. So you're listening for that too. Now the abdomen, just like with adults, look, listen, then feel. Look first, a baby's abdomen should be round. An older child, probably flat or round, and should look symmetrical, should look, normal, no lumps or bumps showing some sort of a hernia. And so you're looking, and then you listen for your bowel sounds in all 4 quadrants, and then you feel to see if it's soft. At Children's Hospital, they also want the liver palpated on every child. Now your liver's on your right side, up under the costal margin, so you have to push down deeper than the ribs and then up. It's okay to not feel the liver, to have a non-palpable liver, or to just feel the base of the liver. You can just barely bump your fingertips into the bottom of the liver. It's just a little more dense. You can feel you're hitting something that's more dense than just the soft, mushy intestines. If the liver is down at the costal margin or distended below the costal margin, you would say in centimeters how far down it is. That is not a good sign. That is not normal. Genitalia. An assessment on a child is not done until you've done a diaper change. You need to say if the genitalia is normal. The other thing you're looking for is diaper rash. Kids, they have nice, moist, healthy skin, good sub-Q tissue. They aren't nearly as prone to skin breakdown from pressure ulcers as adults, but a child in diapers is very prone to diaper rash. So we're looking for the skin integrity in the diaper area when we're doing that check of genitalia. You also want to note on a boy if they're circumcised or uncircumcised. Uncircumcised boys have a higher incidence of UTIs, so it's a significant thing to notice. Looking at their back and their extremities, we're looking at their back to make sure that it's straight, particularly kids who aren't upright. They're bedfast or wheelchair bound, have more chance of scoliosis, which is a curvature of the spine. So notice if their back looks straight. Their extremities, do they move all their extremities equally? Are there any contractures to the extremities? And neurologic. I want you to notice the child's age and then decide based on that what you need to check for to see check that neurologic assessment. On an infant, it's just going to be the fontanelle, and they should be able to focus on you and track with you if you move a little bit, and they should be able to move all their extremities well, and the startle reflex and a few reflexes like that. An older kid, a 2-year-old, if you roll a ball to them, they should be able to stop it and hopefully roll it back to you. You may be able to incorporate play here into doing this neurologic assessment. A 4-year-old, can they hop up and down with you? So generally, particularly with that neurologic assessment, you can often incorporate in play. And that is the end of Chapter 6.